All right. For those joining us, we will be getting started in about a minute or two, and we are recording. All right, we'll get started in just a moment. Trying to give everybody a chance to get logged in. Alrighty, it's 2:01, so we'll go ahead and get started. If you join us late, we are happy to have you. I do recognize this is coinciding with a couple other things that we are hosting from GaPQC, so thank you all for your time and for joining us today. We'll start with a couple quick reminders and announcements, and then we'll dive right in. As a reminder to everybody, if you would please complete the ONN survey. This will help us in the planning of the initiative, as well as help us better support our quality improvement efforts. Also, the Center for Health Equity, Education and Research, or CHEER for short, is nearing the end of enrollment for their CHAMPS program. The CHAMPS program helps to decrease racial inequities and improve breastfeeding rates. A big shout out to Colquitt and Wellstar MCG who have already enrolled. That's very exciting to know that we've got some Georgia representatives doing that. And if you're interested, there is the link in the slide. And as a reminder, as far as that goes, these slides will be shared via the GaPQC website, so you can find it later. Also, another quick reminder, don't forget that we have corresponding micro lessons that relate back to these webinars. These are really short, digestible educational lessons that can be found on Georgia Train, and you don't need any special anything to join Georgia Train. You just go on and sign up for an account. So please utilize those resources. They're really great lessons and are very manageable, particularly if you're a nurse and have a few minutes of downtime on a shift. Very, very doable in those sort of lull moments if those exist. Another quick reminder, has your hospital completed the MPINK survey yet? We have been told that only 20% of Georgia facilities have completed it so far. This is a nationwide survey that examines maternity care practices and newborn nutrition, and it is conducted by the CDC. Every birthing hospital should participate, and you should have heard from Batale. It's the company that's actually administering the survey. They have been reaching out via phone calls, not email, phone calls. So if you have any questions or you're not sure if your facility has participated yet or has heard from them, please reach out to this email. If you have additional questions, I'm also happy to help field those questions as well. New announcement. We are going to start hosting monthly office hours to help provide you and your units time to ask quality improvement or policy questions that you may have. We are going to start our first session on Monday, May 20th from 1 to 2, and I will send out a Teams meeting invite after the webinar today for that to our listserv. We would love to have you join us. And if you have topics or questions that you want to submit beforehand so that you know that they'll be covered, please feel free to reach out to me via email and do that. So we look forward to seeing you at that. And feel free to just pop in and join even if you don't have specific questions, because we can all learn from each other in this process. Very
Hey, Laura,
exciting.
can I interrupt you for just a minute? I think there's folks on that meeting from the series that was canceled that Kimberly sent out. Linda, could you go and see if you can find that link and tell those people to come over to this meeting?
Oh, they might not have. That's a great question. They might not have realized.
Yeah, I've been fielding a couple of texts about it, and I think
I'm sorry.
no, I don't think it's anyone. I think it's just, Kimberly canceled that series, but unless people took it off and added this one, then they still might have the other link.
Okay. We're still admitting people. Sorry, guys.
Yeah.
And if you or somebody you know needs invites to any and all things, please reach out to me via email. We will add you on. And hopefully we won't have dueling invites going forward. Linda,
Okay, I'm
feel free
sorry to have interrupted.
No, it's okay. I was gonna say, Linda, feel free to jump in and interrupt if you need to. On some exciting news, we've received support from the Georgia Perinatal Quality Collaborative to offer 17 scholarships to the Emory Conference on Breastfeeding that was held in early April for on-demand viewing. If you would like to participate or your hospital team members would like to participate, it's going to be a first come, first serve option. So please jump on it if you would like to do that. It's a wonderful conference. Many of us that are on this now were able to attend, and it was great. Learned a lot of great information. So the link is there, and like I said, we'll share these slides as well. And that is the code to get the free entrance, and that will be available until the end of June. So June 30th is when that will expire. So about a month and a half, if you would like to do that. Hopefully those that weren't able to be there in person will be able to take advantage of this. Did you have anything else to add to that, Claire?
I just put in the chat that the scholarship is for 75% off the registration for on demand. So it's really, we hope it'll make the on demand access really accessible. And as co-chair of the planning committee for the Emory Conference on Breastfeeding this year, we really appreciate support from the GaPQC to get this education out to participants of this initiative. A lot of the topics are really relevant to the work we're doing. So thanks for making that more available to people who weren't able to travel to Atlanta.
Yeah, and the fact that it's on demand is great. So you can just kind of watch one here and there as you have time and availability. So lots of great content. All right. I'm still letting people in, so welcome to those that are just joining us. And I'm going to switch screens and we will get started with our webinar today.
Okay, yeah. Thank you, Laura. Let me pull up my, and get to the right screen here. Share PowerPoint Live. All right, we're going to try PowerPoint Live again. Here we go. Does that look right? Everyone see it? Can you see it, Dr. Giesling?
Yes, ma'am.
Okay, I'm so happy to be able to introduce Dr. Brandy Giesling to you all, who's going to present our topic today, which is when highs and lows collide, preventing and managing hypoglycemia and hyperbilirubinemia. It's like a tongue twister day. Dr. Giesling began her training with her undergraduate degree at Augusta State University, her medical degree from Mercer University School of Medicine, and completed her pediatric internship and residency at the Medical College of Georgia. She's board certified by the American Board of Pediatrics and is a fellow of the American Academy of Pediatrics. She's a leader here in the Georgia chapter AAP. She has a real passion for breastfeeding. In 2018, she became board certified as a lactation consultant. She's a member of the Academy of Breastfeeding Medicine, which you're going to hear a lot about today. She's certified by the Georgia chapter AAP as a breastfeeding friendly pediatrician. And she currently serves as the new co-chair of our Georgia AAP Breastfeeding Committee. She also chairs our advisory committee for the Breastfeeding Friendly Pediatrician Program and is a member of the EPIC Breastfeeding Advisory Committee too. So I think the GaPQC is like the last in the frontier of opportunities that Dr. Giesling has had to share some of her expertise. So I'm really happy to turn the time over to Dr. Giesling.
Thank you so much, Claire, and thank you so much for having me today. So am I muted?
No, you're good.
Okay, perfect. So let's do some level setting to start. The 2023 updated AAP statement on breastfeeding and the use of human milk reminds us from the start that breastfeeding and human milk are the normative standards for infant feeding and nutrition. The short and long-term medical and neurodevelopmental advantages of breastfeeding make breastfeeding or the provision of human milk a public health imperative. Of course, this is why we are all here participating in the Georgia Perinatal Quality Collaborative Optimizing Newborn Nutrition Initiative. So hypoglycemia and hyperbilirubinemia are both common neonatal issues. Hypoglycemia more likely occurs in the first day or two of life, whereas hyperbilirubinemia more likely occurs later on in days 3 through 5. We'll start with hypoglycemia. Standardization of practice in the healthcare setting has been revealed to improve safety and patient outcomes, giving the differing recommendations from the various pediatric associations, as well as the sparse evidence regarding screening, diagnosis, and treatment of hypoglycemia. It is unclear how varied newborn hypoglycemia practices are across nurseries in the United States. The Better Outcomes Through Research for Newborns Network had identified hypoglycemia as an area needing further evaluation. So let's take a poll. We are curious how you all would answer this question from the CDC's MPINC survey. You can participate by answering yes or no in the chat. Does your hospital perform routine blood glucose monitoring of full-term healthy newborns who are not at risk for hypoglycemia?
Yay, I'm seeing some no's. We're gonna have a lot of polls, so get your fingers ready on the keyboard. Okay, this is good to hear.
Oh, great.
Sorry, I'm having trouble finding where I am in the slides. Okay, yeah, here we are.
Yeah, there's like a lot of no's. That's great. Awesome. All right. Hypoglycemia is the most common metabolic disorder of the newborn and perhaps the only readily preventable cause of neonatal brain injury. Despite this, management of neonatal hypoglycemia has for decades been based on extremely limited evidence. If you aren't familiar with the Academy of Breastfeeding Medicine, they develop clinical protocols for managing common medical conditions that may impact breastfeeding success. Hypoglycemia is actually the topic of the first clinical protocol that ABM wrote. It was revised in 2021. These protocols serve only as guidelines for the care of breastfeeding mothers and infants and do not delineate an exclusive course of treatment or serve as standards of medical care. Variations in treatment may be appropriate according to the needs of the individual patient. As mentioned, standardization of policy is important to patient safety and improving outcomes. The ABM protocol is written to provide practitioners with pragmatic, evidence-based guidelines to keep infants safe while minimizing unjustified interventions and adverse effects, such as heightened parental anxiety, excessive painful procedures, unnecessary supplementation, decrease in breastfeeding, and avoidable NICU admission. So let's talk about hypoglycemia. Infants are well hydrated via the placenta at birth. We know that urine output exceeds intake days 1 through 3 during secretory activation and the process of lactogenesis 2, and the milk becoming more plentiful. Small colostrum feedings of 2 to 15 mLs are physiologic. Remember, breastfeeding is the biological norm. They are appropriate for the size of the infant's stomach. They're easy to manage as an infant learns to coordinate suck, swallow, and breathing. And a neonate has sucking needs greater than the quantity they need to eat, which helps to stimulate milk production. These small, frequent feeds are sufficient to prevent hypoglycemia in healthy term infants. The term hypoglycemia refers to a low blood or plasma glucose concentration and reflects a relative imbalance between the supply and utilization of glucose, but it does not consider the supply and utilization of alternative fuels to glucose covered under the broader concept of metabolic adaptation. In healthy term human infants, even if early enteral feeding is withheld, the phenomenon of transitional hypoglycemia is self-limited, without clinical signs, and considered to be a part of the adaptation to postnatal life, as occurs in most all mammalian species. It's self-limited. It resolves within 2 to 3 hours, even if the feedings are withheld in normal term infants. However, profound, persistent, or recurrent neonatal hypoglycemia, especially in a term previously healthy newborn with no risk factors, invariably presents with abnormal clinical signs and may reflect genetic, metabolic, or endocrine dysregulation or defects and require more aggressive evaluation and care. Despite over 60 years of recognition that low blood glucose can cause neurological compromise, we still do not know how low, for how long, and in which specific infants. New evidence has come to light, but so have new varying recommendations based on differing perspectives. Also, peripartum care of the mother and newborn has changed dramatically in the past 6 decades, with infants staying with their mothers and encouraged to feed sooner. As the normal range of blood glucose is different for each newborn and depends upon a number of factors, including birth weight, gestational age, availability of energy stores, feeding status, and presence or absence of disease, any hypoglycemia management must account for the overall metabolic and physiological status of the infant and should not unnecessarily disrupt the mother-infant relationship and breastfeeding. So as you can see on this chart, the various pediatric societies have different opinions as to what is actually considered the glucose operational thresholds. Neonatal hypoglycemia is a leading cause of admission of neonates to the NICU. Treatment for neonatal hypoglycemia has typically included supplementation with formula or, in some cases, IV glucose administration. Admission to these treatments, though effective in treating hypoglycemia, can interrupt exclusive breastfeeding and interfere with mother-infant bonding. The NICU is almost a certain interruption to the establishment of breastfeeding and lactation. Proper assessment, monitoring, and management of blood glucose is key. As has been discussed in past webinars, assessing dyads for risk factors is key. At-risk neonates fall into 2 main categories. Those with excess utilization of glucose, which includes the hyperinsulinemic states, and the second group is the inadequate production of the glucose. The 2021 ABM protocol has this table of conditions that may put an infant at risk and for whom routine monitoring of blood glucose is indicated. This slide has the maternal factors. And this slide lists the neonatal conditions. These two slides are a good check back to ensure at-risk infants are receiving routine monitoring of blood glucose. Neonates at increased risk for developing neonatal hypoglycemia should be routinely monitored for blood glucose levels, irrespective of the mode of feeding. So what are the signs and symptoms of possible hypoglycemia? They fall into two categories: the neurogenic adrenergic, which is the sympathetic nervous system activation, and the neuroglycopenic, which is the brain dysfunction due to inadequate glucose. And as you can see, some of the symptoms you can see commonly are the irritability and the tachypnea and the sweating. End stage or towards the end, you would definitely see you can see seizures, coma, cyanosis, and even apnea. The Academy of Breastfeeding Medicine states that dextrose gel plus breastfeeding should be considered the first-line oral treatment of infants with hypoglycemia. Dextrose gel is inexpensive, it's safe, and it's easy to administer. It is important to make sure you apply it properly. It does not suppress the feeding behavior or the cueing like formula can. So who uses dextrose gel plus breastfeeding as your first-line treatment? And let's answer yes or no in the comment section. Awesome.
Looks like we're preaching to the crowd today, Dr.
Yeah,
Beasley.
this is awesome. Perfect. Yeah, it was even more than I thought. That's great.
Well, maybe people who aren't commenting are the no's.
Yeah, no worries. So here are some general management recommendations. No study has evaluated the optimal timing and intervals for glucose screening. The ABM 2021 states that glucose screening should be performed only on at-risk infants and those with clinical signs compatible with hypoglycemia. You can refer to the protocol for details on screening. The protocol also includes this handy little chart. As you can see, the green is for all infants, the yellow is for those who are at risk, and the red are for babies displaying signs and symptoms of hypoglycemia.
Sorry, this isn't very clear when it's blown up big, but you can see it really well in the protocol.
And this chart is a great kind of guideline to treatment, and it also includes the gel, as you can see. And it goes through the different, based on the glucose levels, where you have 20 to 25, and then 25 to 34, then 35 to 45, and then greater than 45. But I highly recommend it. We really like this protocol. In terms of general management recommendations, clinicians must identify and document risk factors, coexisting conditions, clinical signs, and make assessments and decisions to avoid harm from hypoglycemia. But it's also to avoid iatrogenic harm, such as the effects of separation of mother and infant. Clinicians need the skills necessary to distinguish between abnormal feeding behaviors, suggesting illness, and mere reluctance to feed. You can review the management recommendations in the ABM protocol, but early and exclusive breastfeeding meets the nutritional and metabolic needs of healthy term newborn infants. These are topics that have been covered in many past webinars. Similar breastfeeding supportive hospital practices are outlined in the AAP statement, with a reminder that education of healthcare staff may be important, but is insufficient as a single measure to increase breastfeeding initiation.
Yeah, it was fun as we were preparing these to see all the topics that we've covered in past webinars show up in all these recommendations.
The ABM protocol lists recommendations for supporting the mother and family that should be considered as a part of policy or protocol. We've highlighted in green the elements covered in previous GaPQC education. We want to provide parents with verbal and written information that explains why their baby is receiving extra support and blood glucose monitoring. We want to teach mothers to hand express and give the resulting colostrum to the infant. We want to consider antenatal, perinatal milk expression in mothers with gestational diabetes, as well as delayed baths to further support maintenance of normal glucose homeostasis among high-risk newborns. We want to provide manual and or mechanical breast expression with appropriate frequency, ideally the magic 8 times in 24 hours, until the baby is latching and suckling well to protect mother's milk supply. We want to keep the infant at the breast or return the infant to the breast as soon as possible to maintain breastfeeding as well as breast milk supply. We want to encourage continuous skin-to-skin care. Skin-to-skin care may lessen the trauma of intervention while providing physiologic thermoregulation and metabolic homeostasis. We want to delay or omit the bath unless medically indicated. This may reduce stress and maintain thermoregulation. We want to provide expert, consistent, and sustained breastfeeding support by trained, experienced members of the healthcare team. We're curious, who is using donor milk rather than formula to supplement breastfed infants when medically indicated?
And here's a few of y'all out there.
Oh, good. Oh, there are some.
It's a lot more than I think when we started the initiative a few years ago are answering yes. So
that's awesome.
Something to consider.
That's right.
And we put up these images from some of the past webinars and from the micro lessons. If you're considering this, there's Summer's putting the links in the chat to some of the webinars, and the micro lessons are available on Georgia Train, which Laura put up the slide at the beginning as a reminder to register your team for Georgia Train to get access to the micro lessons.
Does your hospital have a policy about the storage and handling of milk expressed prior to delivery? You can also answer in the chat. Pregnant women with diabetes are candidates for harvesting colostrum prenatally. This can be brought to the hospital to use for supplementation after breastfeeding. There is also a micro lesson available on Georgia Train website on antenatal milk expression.
I think this is something to consider developing a policy about, because if you haven't seen it yet, you'll see it soon enough. I've had a lot of questions from different hospitals about how to manage this and making sure that your milk storage and handling policies include how to handle milk that was expressed prior to delivery. If that's something you need resources on, I don't have an easy answer, but you can reach out and I can share what, some of the other policies.
We've addressed many of the recommendations in previous content, but not delayed bathing specifically. According to the American Academy of Pediatrics, delayed bathing of the newborn until 12 hours after birth allows more uninterrupted skin-to-skin contact and has been shown to improve exclusive in-hospital breastfeeding rates. The AAP does not provide a recommendation on infant bathing except in cases of maternal HIV infection, hepatitis B or C virus infection, herpes simplex, or other infections transmitted via blood or other bodily fluids. This guidance is based on expert opinion. Has your hospital transitioned to delayed bathing in most cases? Awesome. We got a yes.
Well, 6 hours is better than immediately.
How much time is everyone usually delaying the bath by? 12 or 24 hours?
Some of each, it looks like.
Yeah, that's awesome.
Oh, Eva, that's interesting. 24 for a preterm. What's a cutoff for preterm? Like the classic definition? That's interesting because it kind of is looking at the risk factor, like how there's a higher risk factor for preterm infants for hypoglycemia. So, all right. I feel good. We're doing good on time and getting great response to the polls.
Yeah, absolutely. Thank you, everyone, for participating. Policies around when supplementation is medically necessary can create friction between team members and departments. We encourage you to meet and review a few cases in which an infant developed hypoglycemia and maybe ended up in the NICU. What were the risk factors? Who assessed them? Do a root cause analysis. Was there a golden hour? Early feeding and milk expression? Was feeding properly addressed? What would need to change in order to have prevented the NICU admission? Was baby being breastfed at discharge? Was proper follow-up scheduled? Did the family have access to outpatient lactation support, and were they referred? Families are best served when all members of the team collaborate on policy development and implementation. Does your unit have an infant feeding committee or task force that meets regularly to review and develop feeding policies and protocols? Put yes or no in the chat.
Yeah, not an avalanche of yeses to this one.
Yeah.
A few though, that's good.
Yeah.
This is something we've encouraged a few times throughout the initiative is, get, some hospitals have a breastfeeding committee, but it could just also be if we integrate breastfeeding into all of our teaching around infant feeding, like we talked about in a few webinars, like looking at, doing kind of root cause analysis. You could use the 10 babies that you're auditing for the collecting data for the initiative and do root cause analysis and find one specifically about hypoglycemia if you wanted, or you could just think of a patient and do that kind of reverse questioning. And we have a few resources that the webinars that are listed here are good options for this topic. And then also we have a discussion guide. We have a discussion guide that we did kind of early in the initiative. If anyone needs a copy of that, you can email Laura or I, and we can get it to you. But it's called, it went along with the webinar called Where Are We and Did We Get Here on Purpose? And it has topics to use in regular meetings of an infant feeding committee, a multidisciplinary committee. And we'd be happy to share that out again. It's probably on Teams too, but we can help you find it.
Moving on to the second topic, which we encounter more often closer to discharge, and what I see as an outpatient pediatrician rearing its head in the first week of life once the mom and the infant are discharged home, hyperbilirubinemia. Breastfed infants who are breastfeeding tend to have higher mean concentrations of bilirubin than babies who are not breastfed. This is believed to be physiologic, and there is some evidence that bilirubin in neonates is beneficial because bilirubin is a potent antioxidant. In breastfed infants, 9 to 10 feedings a day is associated with lower bilirubin concentrations. 7 or fewer are associated with a higher bilirubin concentration. So let's take another poll. Would you say breastfed infants in your unit receive more than 8 feeds a day on average?
I also wonder if this is impacted by really early discharges for typical birth situations. I feel like discharge is fairly fast these days.
Yeah, and that's a good point, Laura, and that Linda's mentioning that, like, if we don't use the first 24 hours in the average, like, we're going to be more likely to hit more than 8. And I know it's really a struggle to get in 8. but I thought this data, and sorry for the typo on this slide, but when we only have 7 or fewer, that's going to be a risk factor for higher bilirubin concentrations. So I think if they're not feeding frequently at discharge, encouraging and really reinforcing that frequency at discharge, like you said, Laura, is really critical.
We encourage you to make sure your policies and protocols are evidence-based. This is the most recent AAP clinical practice guideline published in 2022, and there is an accompanying technical report. The AAP convened a clinical practice guideline committee with memberships that included neonatologists, hospitalists, primary care pediatricians, a nurse, and breastfeeding experts. They reviewed guidelines from the Northern California Neonatal Consortium 12 and the Academy of Breastfeeding Medicine. Because the new evidence is insufficient to derive specific treatment thresholds by quantitatively estimating the risk and benefits of different approaches to care, the committee began with the previous AAP guidelines. On the basis of an evaluation of evidence published since 2004, the committee raised the phototherapy thresholds by a narrow range that the committee considered to be safe. The committee also used new research findings to revise the risk assessment approach based on the hour-specific bilirubin concentration and the approach to rapidly address elevated bilirubin concentrations defined as escalation of care. So let's talk about language from the Academy of Breastfeeding Medicine. Although some early studies reported no differences in bilirubin concentrations between breastfed and formula-fed infants, subsequent studies using larger sample sizes and more robust research demonstrated a strong association between hyperbilirubinemia and breastfeeding compared with formula feeding, especially when breastfeeding was exclusive. Nonetheless, in comparison with previous data, Butler, in a study of the relationship between stool production and jaundice in healthy breastfed or formula-fed newborns, found significantly less stool production in formula-fed infants and no difference in stool production or bilirubin concentrations in the first 4 days between breastfed and formula-fed infants. Based on this body of evidence, 2 broad categories of the association between breastfeeding and jaundice have been described. Jaundice, which occurs in the first week in association with ongoing weight loss, has been termed breastfeeding jaundice. Breastfeeding-associated jaundice, breastfeeding non-feeding jaundice, or starvation jaundice. However, as this jaundice is almost always associated with low intake rather than breastfeeding per se, in this protocol, it will be called suboptimal intake jaundice. For our discussion today, we will focus on this, suboptimal intake jaundice. Suboptimal intake jaundice is different than breast milk jaundice. For purposes of this webinar, we won't discuss the treatment or management of breast milk jaundice and refer participants to the protocol referenced. Bilirubin encephalopathy is a rare neurological condition that occurs in some newborns with severe jaundice. Kernicterus is a condition where high bilirubin levels in the blood are deposited in the brain tissue, causing irreversible damage to the brain. The most recent studies in high-resource countries suggest that in the absence of significant comorbidities, such as sepsis or Rh hemolytic disease, kernicterus or chronic bilirubin encephalopathy occurs in about 1 in 200,000 live births, and only when bilirubin levels exceeded 35 milligrams per deciliter. In lower resource countries, bilirubin encephalopathy and comorbidities are much more common, so that kernicterus can and does occur more frequently and at lower bilirubin levels. Even in high resource countries, extreme hyperbilirubinemia in apparently healthy breastfeeding infants can cause kernicterus. Late preterm infants born between 34 and 36 weeks gestational age and early term infants born at 37 to 38 weeks gestation have decreased breastfeeding rates compared to term newborn infants. There are multiple factors that may lead to breastfeeding difficulties, including maternal delayed onset of lactation, infant immaturity, decreased effective milk emptying, and separation of infants from their mothers. Inadequate human milk intake in the first days after delivery can contribute to longer hospital stays and higher rates of hospital readmissions. Infant supplementation, when necessary, should preferably be with express maternal milk or pasteurized donor human milk when available, because formula supplementation has been associated with increased exclusive formula feeding at discharge. Infant supplementation, when necessary, should preferably be with expressed maternal milk. Colostrum feedings increase stooling in the newborn, which increases bilirubin excretion in the stools. The need for phototherapy in an otherwise healthy infant without signs of dehydration and/or insufficient intake is not an indication for interruption of breastfeeding or for supplementation, unless bilirubin concentrations are approaching exchange transfusion levels. Infants requiring phototherapy benefit from remaining in close proximity to the mother to facilitate cue-based feeding and additional breastfeeding support. Whenever possible, phototherapy should be provided in the mother's room or in a room in which the mother can remain with the infant. Interrupting phototherapy for breastfeeding does not impact the overall effectiveness of phototherapy if it is otherwise appropriately used. Can you use a billy blanket or pad on the infant's backside while the mom is breastfeeding the baby? In some cases, skin to skin can still be facilitated with the phototherapy lights on both the parent and the baby. Parent will just need protective eyewear. And let's take a poll. Would you say your unit practices family-friendly jaundice management?
Not a lot of enthusiastic yeses. Oh, good. Here come a few.
Oh, good. Phototherapy in the room.
I guess it depends on what your standard is.
And here is a sample Billy tool. It's an AAP practice guideline that includes those phototherapy thresholds. So again, you can use the Billy tool and input the baby's age and level of bilirubin, and then it'll kind of give you some guidance as to whether the baby needs phototherapy and when they would need follow-up. The Academy of Breastfeeding Medicine outlines these evidence-based strategies for preventing or ameliorating jaundice in the breastfeeding infant, which will all sound familiar. This is why we are doing this work.
Yep, no surprises here.
The Academy of Breastfeeding Medicine lists these risk factors for hyperbilirubinemia. We encourage your team to integrate more and more better assessment of risk factors to better anticipate who will need support. Some of the common risk factors for the mom would be diabetes, obesity, cesarean delivery. For the baby's gestational age is pretty significant, and also if the baby has significant bruising. And here are the risk factors from the AAP, which is a little bit more comprehensive. And wrapping up, a review from the American Academy of Pediatrics on breastfeeding supportive hospital practices includes many strategies covered so far in previous webinars and micro lessons. So we want to definitely make sure we're breastfeeding in the first hour after birth. We want to make sure we're exclusive breastfeeding, rooming in, of course, breastfeeding on demand, judicious use of pacifiers, and we want to make sure we're providing information on breastfeeding support after discharge. Frequent feedings on demand at least 8 to 10 times in 24 hours decreases newborn weight loss, the need for supplements, the risk of clinically significant hyperbilirubinemia. Continuous rooming in with frequent exclusive breastfeeding is recommended. You want to avoid supplemental feedings unless breastfeeding technique and frequency has been optimized first or when supplementation is medically necessary. Delayed bathing of the newborn until 12 hours after birth allows more uninterrupted skin-to-skin contact and has been shown to improve exclusive in-hospital breastfeeding rates. Formal hospital staff training should focus on updating knowledge and techniques for breastfeeding support and emphasize the role of staff in decreasing disparities and providing culturally competent care. All right, guys, any questions?
Feel free to unmute yourself or type them into the chat.
I was worried that we wouldn't have time. Let me see. Sorry, I was getting a question. Thought I was getting a question by text, but it's about getting back into the meeting. While you have all of each other here, I think it would be interesting to hear from each other, you know, what are some of the challenges that you're facing? I see Deborah's asking about antenatal milk expression. I think, yeah, really reinforcing that, you know, in mothers who are a good candidate for that, the idea is that, you know, if we anticipate that the baby is at risk of hypoglycemia due to the maternal, you know, insulin resistance, then having the express colostrum available in advance can really help with avoiding having to use supplemental donor milk or formula. Has anyone been doing that at their hospital that wants to share a little bit about what that experience has looked like, how they manage antenatally expressed colostrum, or are families just kind of managing it on their own? That's what I've seen is folks who are like, I'm doing it, I'm bringing it in a cooler and I'm supplementing because I'm trying to avoid it with this baby when, you know, we're trying to prevent the hypoglycemia rather than treating it.
Claire,
Anyone
this
have
is
it?
Deborah.
Yeah.
I can share that when I've been asked to go over and speak with a mother, I discuss about antenatal expression, but I do also refer her to speak with her OB, giving, you know, making sure with the medical history that she's got. And then I really encourage that. And then also we have an area where that, you know, could be stored if needed, providing them with the, you know, syringes if needed. And with the nurses that are here in NICU, I talk about it a lot for them and their with their deliveries. You know, if their OBs will actually, you know, say yes, you can do that. I encourage it to the nurses here who are, you know, pregnant and going to deliver too, because I feel like if they're doing it on their aspect, as they get a little bit more you know, kind of working with the mothers that are in there or in the community as well, they can also bring that knowledge about how important antenatal expression is. Because, you know, if they can start making, you know, have lots of syringes ahead of time, and this could, you know, possibly avoid some of those hypoglycemic type episodes if mothers just getting that information out there prenatally, which I find is not happening.
I think it's happening in pockets. I think there's some folks that are like, a lot of people are doing it even that don't have any risk factors. And in some places, folks that do have risk factors aren't hearing about it. Has anyone on the call done the micro lesson, listened to the micro lesson that we did on this? Nope. So check it out. We talk about elements of a policy. You know, there's some folks who are not going to be good candidates if they're at risk of preterm labor. It should be, you know, at the end of pregnancy, and discuss some of the ideas around maybe the advantage of it is partly in getting mothers familiar with hand expression so that then they can be integrating hand expression right from, you know, after their baby's born as well. Dr. Giesling, have you seen many mothers in your area doing this?
Yeah, I've had a few show up to the hospital, and when we start talking about supplementation, they pull out their little cooler and they have their milk they expressed. So they're kind of managing, like everybody said, kind of managing on their own and kind of keeping up with it themselves in their little coolers. I definitely think we need to get the word out. I think there are a lot of people that still don't know about this.
So, Marilyn, you bring up a good point. We don't recommend pumping prior to delivery. It's only hand expression, not pumping. But yeah, I'm happy to, you know, we encourage you to register for Georgia Train and take advantage of the micro lessons and share that with, folks on your team that might not be ready to make a commitment to listen to hour-long webinars at a time, but want to get those little bits of, shorter, manageable bites of information. So like if your committee was going to discuss having a policy around how to manage, handle, and, feed prenatally express milk, then you could have, you could use the micro lesson as like the basis for discussion and have that be like a pre-read for the group. And it's not hard to make a Georgia Train account and find the micro lessons. And Laura and I and Summer and Linda can all help with getting access to that. I think the important elements of a policy, just to do a quick review of that, is like not refusing milk when people bring it. I think that's come up at a few places where they're like, we don't have a freezer on mother baby, things like that. I think kind of the solution has been encouraging families to bring it once the baby's actually born and not bringing it when they're admitted in labor or to deliver, because then the milk it's in such small quantities that it can thaw. And then if your policy is that thawed milk has to be used within 24 hours, then you start bumping up against your policy versus what the parents are, if the parents are feeding it, and if you're it gets complicated. So the kind of where I've landed talking to folks is freeze it in capped syringes and bring it once the baby's born rather than when you're in labor, so that it doesn't, if there's not a freezer accessible at the hospital, you can use it all within the 24 hours. Maryland, yeah, that's concerning, especially if they have risk factors for preterm labor that folks are pumping. I think if somebody's trying to go into labor and they're full term, then that's one thing, a different thing, right, Dr. Giesling?
Yeah.
That's good to hear.
Here in Augusta, we were starting to work with the residents in the clinic and the faculty about talking to the patients while they're pregnant, because like you guys have mentioned, a lot of my patients come in and they've watched TikTok and they're doing the electric pumping, and it's like, no, don't do that. So we're working on signage in the clinic for the patients while they're pregnant, to kind of know what they should be doing, when to talk to their doctor about it, and if they're a candidate.
Oh, that's an interesting approach, to have like a poster, a flyer up in the exam room, something like that.
Yes.
Thanks for sharing, Linda. Yeah. We're all like, TikTok, no.
I know. I cringe when I hear TikTok, but TikTok said so.
TikTok is not your doc.
I love that.
Really.
That's super cute.
Yeah, I mean, for sure, anyone talking to anyone about prenatal milk expression is like, clear it with your obstetric provider, because there's some folks that are not a good candidate. And, ensuring that it's hand expression and not pumping. There's just significantly more nipple stimulation with pumping than there is with hand expression techniques. Oh, thanks, Linda. Put how to set up your train account. So would it be helpful to have a micro lesson on family-friendly jaundice management? I guess not if people aren't using the train, okay, the micro lessons, but we can develop that. And then there'll be a micro lesson on both hyperbilirubinemia and hypoglycemia available. One will be up around the end of May, first day of June, and then the second one will be available in June. We'll have a micro lesson on each topic. We'll divide these up into 2 micro lesson topics so that it's a little bit more digestible, and kind of connecting how these practices can help prevent, but they won't go into all the technicalities about, things that are available in those 2 policies that are, or 2 or 3 policies that are linked in the chat. Oh, good to hear, Kelly, that you're using the micro lessons. Any other questions for Dr. Giesling while we have her available? Any kind of unusual scenarios you face that you want some feedback on around either of these two options? When we're preparing it, I think we really just wanted to kind of remind folks that thinking through how to operationalize assessment, because the kids that get readmitted, like for hyperbiliary particularly, like they had multiple risk factors that should have been like very clear. And of course, we know some of that is like families struggling to comply when they get home. But we're hoping that's part of the initiative that more hospitals are integrating assessment for lactation risk. And, lactation risk assessment overlaps pretty clearly with preventing hyperbilirubinemia and hypoglycemia, right? Like when we have families that have the babies born preterm, mom has gestational diabetes, mom has high blood pressure, insulin resistance, cesarean delivery is, common, but it can be a risk factor for delayed lactogenesis. So making sure that you're starting to consider how to operationalize some of those risk factors and prioritizing families, dyads that have a lot of those risk factors for your limited skilled lactation care is what we hope that you all are taking from these webinars. So thanks everyone for being here. And thank you so much to Dr. Giesling for making time to share her expertise and be a voice for breastfeeding, specifically among her peers. And I see another breastfeeding friendly pediatrician, Dr. Paez, is here. She signed in as Imagine Pediatrics, but
Awesome.
It's great to have pediatricians hearing some of these messages.
Thank y'all so much for having me, and thank y'all so much for coming.
Laura, will you send out the a follow-up after this, maybe at the end of the week or early next week? Okay.
It'll probably be tomorrow or Thursday, maybe.
I can check with you to make sure you got the PDF of the slides and then the links that we put in the chat that you could send out along with the